everyone, and welcome to the next episode of As the Walk Returns. And today I am really happy to be talking to Sonia Harmer. And Sonia, we've worked together for how long now? Has it been 2 years, 3 years?
2 years.
2 years. Okay, all right. So can you talk to me a little bit about your journey into, well, senior living is kind of a broad term, but what did you do prior to working for us at the Ridge?
So I have been a nurse for just celebrating 30 years this
Wow.
year, and I've had the most beautiful career. Have dabbled in a couple of different fields. I did spend 10 years in the emergency room, and about 10 years into that, had a life-changing situation happen and decided that maybe that wasn't my career path anymore. Had a friend who started talking to me about hospice services. I did not know anything about that particular field of nursing. Was introduced to it and spent over half my career as a hospice nurse.
Wow.
And yes, and I feel that it was a complete blessing that I did have something that changed my course and introduced me to such a beautiful field, and how it had enriched my life and kind of changed my perspective on nursing. And then decided 2 years ago to start a new journey and a new path into assisted living.
Wonderful. I definitely can see the overlap in all three, but certainly hospice to senior living is a very strong correlated line, I would say.
Yeah.
That's so interesting. So that during nursing school, and again, we're not 30 years is a long time in to be a nurse, but was that not part of like a career path that they talked about much, whether it was senior living or hospice?
No,
Wow.
no. Back in the day, I don't even remember one class speaking about hospice. We talked about, of course, the pioneer Florence Nightingale, and we knew about Dame Cicely Saunders, but it was more of an exam setting. But we never had like an opportunity to go into an assisted or long-term care and learn about hospice. And so when I started this new journey, it was all brand new to me, and I had to develop my own feelings about what this looked like and how this was going to be for people since we had no experience in an educational level.
Wow, that would be an interesting conversation to have with current nursing schools, and if this is a focus, knowing that, we've had some previous people, from the industry talking about the explosion that we're seeing now and going to be seeing over the next several years with the boomers,
Mhm.
aging and needing care and having those conversations and having that workforce available. I obviously has to start in nursing school. There's so many different ways you can be a nurse. So anyway, thank you for sharing that. So Sonia, over the last 30 years, I mean, whether it's an emergent relationship, long-term relationship, how have you found success in gaining family and now residents trust?
I think one of the most important things when you're first starting out, you really have to listen. You have to figure out where they're at on their journey, what acceptance do they have of the decline of their loved one.
Hmm.
And I think building that foundation of completely, totally understanding and not trying to correct it, not trying to educate right in the very beginning. The beginning is all about listening and realizing and formulating in your mind what is going to be the best thing for this family. Where can we be? Is it a religious thing? Is
Hmm.
it a cultural thing? Is it how how do they view death? How do they view living? And what does that look like? And I think building that trust with them that they know that they can confide in me, tell me anything and everything that they're feeling, and there won't be a judgment. There, it is, I always used to kind of say, it doesn't matter what the cultural belief is or what the religious belief is. I'm still going to join them on the journey and I'm going to make it look as peaceful and as wonderful as I possibly can for them. And I think that is where we just start bonding and that trust starts happening because there's going to be no judgment on what they believe or how this will look for them.
Wow. So in the I guess the context of senior living. So now,
Okay.
you may have known these residents for a period of time, and now, we may be faced with a decision, hospice, if it's the appropriate time. Do you typically start those conversations with the residents, with the physician or the nurse practitioner or with the families, or is it all just a very individualized approach?
It's an individualized approach. It just really depends on the relationship I have and who I have it with.
Hmm.
A lot of times it starts with the physician and it's supporting the diagnosis and the decline, right? We have to look at that. Are they going to be appropriate? Because if they're not going to be appropriate for the Medicare benefit, then I don't, there is a sense of anxiety that comes along with it. It's kind of like the same time when we start life. You learn that you're pregnant. There's anxiety. It's the
Right.
same with death. Oh gosh, it's the anxiety of having that introduced. And so I'll talk with typically the nurse, an outside provider nurse, or I'll talk with the physicians and say, this is what I'm seeing because I'm seeing this daily.
Hmm.
And then we'll formulate an idea and a game plan on how to introduce that. I feel very comfortable having and initiating those conversations. A lot of times family will go, okay, Sonia, what do you think? How does this look? What are your opinions? And that right there, Mandy, tells me that they trust me and they
Yeah.
want to know and they want
Right.
to learn. And it's a delicate conversation to have. You approach it with some people, it's very direct. It's this is it. This is where
Right.
we're at. This has got to happen. And other times it's okay, I want you to think about mom 30 years ago. And if mom could look through an hourglass and see herself now, what would she tell you to do for her? And I think that's where those conversations start to happen and just kind of that first introduction. But I always have to have the physician on board.
Sure. What if you have, I know you work out of Utah, so not try to make a broad sweep, but we do tend to see lots of children, lots of decision makers in
Yeah.
Utah. So what if you have family members that are, on opposing sides of that conversation? Do you try and collectively get them on the same page before going to the resident? Or if you know it's going to be maybe a contentious or, a difficult conversation, do you get the resident on board and then approach the family?
Both.
Okay.
And that's a great question. Yeah, both. So if I'm finding that there's family dynamics and we all have them,
Hmm.
dysfunctional family members, functional family members in a culture where there are a lot of children typically, we we usually will set a precedence that who is the main focus? That is going to be the person who disseminates the information. But a lot of times, in cases of that scenario, I would always involve the resident first if they have that cognition to be
Sure.
able to make that decision. And of course, there's always those factors where it doesn't. But then it's the validation that I give to the medical power of attorney is this has got to be they have appointed you as their voice when they no longer can have that voice of their own. So I will set a pretty strong boundary right off the bat with the medical power of attorney.
To say,
And then,
we're going to walk this path together, and you may
yeah,
have some, differing opinions within the family, but you're going to ultimately call the shots here, and we're going to have to work through this together.
yeah. I mean, there is that empowerment, but like you said, I mean, they've never done this. So a lot of them, this is their first
Sure.
time and they
Sure.
need that hand holding. They need that. I don't know if that's the right word to use, but that they need that companionship, right? They need to know that someone's walking side by side with them through this and a lot of times I have worked with families where we're sitting down and we go through a dialogue together on how the verbiage they're going to use with their siblings or the extended family. How does this look? How can I provide comfort but still do the wishes of my loved one? Um, so yeah, we do have those dynamics where it's very, and there has only been a couple of times in my 15 years where we've had to say, this is the legality of this. This is how it's going to look.
Mhm.
That's an unfortunate situation, but it does happen.
Sure, sure. What we've talked about on this podcast that my mom, lives in memory care and she's quite young. She's now 69 years old. So, she to some people might look like, one of the adult children, right? Caring for one of the residents. So
Yeah.
physically, she's in pretty good shape. So, even though I may know some of the signs, of somebody being ready for hospice, what do you typically see? And we'll just use with someone that's a memory, maybe doesn't have any other health diagnosis other than Alzheimer's or some form of dementia. What kind of I shouldn't say like triggers, but like kind of indicators to say, yeah, I think we need to be starting to have this conversation.
So the Medicare guideline on cognitive impairment is that it's a 7A. So there's a FAST score, a functional score that we have to use in hospice. Typically, what we'll look at is a PPS score and a FAST score. The PPS score is more of where that functionality is. On the FAST score at a 7A, which makes them appropriate for hospice Medicare benefit, is that they can't really form a sentence more than 6 words. Now, it can't be a rehearsed phrase though, Mandy. It can't be like, oh, Mandy, how are you today? Oh, I'm doing fine. Well, what did
Right.
you have for dinner? Oh, I had breakfast. It can't be something that they've said over the years. And so when we're interviewing, we want to go something completely off topic. If we find that they literally cannot put those 6 words, intelligible 6 words together and formulate the conversation and the flow, that's a red flag to us right there. That's
Okay.
something that we start looking when we're talking about dementia. The other thing with the dementia that gives us the first cues is their appetite. The
Mm,
gut is the first thing to go in a declining resident. They just don't have that desire to eat anymore. They don't have the sensation. They don't get the hunger pains. And so in dementia, you'll see they'll look for weight loss. That's a huge indicator. Mom's just not wanting to eat. It doesn't taste good. It doesn't smell good. Um, it doesn't look good to them anymore. So those two indicators right there, are they able to flow in a conversation that typically they wouldn't be able to, or they could if they were cognitively aware.
hmm.
And we also look at the weight. Those are our two main factors when we're looking at hospice with dementia.
Okay. So the food.
Hospice outside of dementia, though,
Okay, go ahead. Yep.
yeah, hospice outside of dementia would be looking, and what I say to families sometimes is look at mom and dad. Could they be in a room by themselves in their living situation, be able to cook for themselves, dress themselves, bathe themselves, provide all of the 6 ADL cares that they do, activities of daily living? Could they do that for 6 months and not have a decline? And a
Mm,
lot of families will go, no. And then I'm like, okay, or 6 months, absolutely not. Then we take it down, we dissect it. We get literally down to 30 days. Do you think mom could live in an apartment by herself with all the food that she possibly can have? Everything is there, but would she be able to maintain a way of living? And a lot of families, that is kind of their aha moment of, oh my God, even if I had everything for mom or dad, and I know they couldn't do it 30 days, okay, maybe we need to think about hospice services.
wow, I had not thought of it that way. So let's talk. Thank you for this. That's very helpful. Now I'm not ready for that conversation with my mom yet, but I learned something, so it's something I can educate my family on. So food seems to be a big trigger for families, right? Like someone, as you mentioned, the gut is usually the first indicator, but oftentimes I've seen families that are very maybe hyper focused or obsessed with the food intake, right? Like wanting almost to force feed people because I don't want my mom to starve to death or my dad to starve to death or whatever the situation is. So, is there any more insights or maybe relieving people of some of that guilt? because oftentimes culturally people consider, as Julia Child said, food is love, right? And that's just part of our nature as humans, is to make sure people are well. So how do you work with families to understand that this is part of the disease process? They're truly not suffering, um, if this is what their body is doing.
And that is probably the number one and the hardest things for families when we have that conversation, especially in the Western culture.
Hmm.
Like you said, food is love. When you're sick, what's the first thing mom and dad want to give you? Chicken noodle soup.
Right,
When they are not drinking anymore, oh my gosh, they're going to get dehydrated.
right.
But when I have this conversation, there is a book that I reference a lot. I'm looking at it, but I don't have it with me, Mandy. I'll give you the title of that book. But
Right.
it's along the decisions of making those difficult decisions for loving and grieving families.
Mhm.
When so what I'll do sometimes is I'll go to the physiological level of the gut. When you're full and you're just at the brim and someone tries to give you more, it's actually painful.
Sure.
Everything's starting to slow down when it comes to the physiological signs of the body when it's in the starting the dying process or the declining process. So the gut starts to slow down. If people start to try to force feed someone who is not hungry, or when the gut starts to slow down, you have more potentials of having a GI blockage.
Mhm.
The gut starts to slow down. You can get an ileus of where there's actually a paralysis of a system. And then the constipation portion of it becomes because you're pushing food in, the gut's starting to slow down. They're feeling this bulkness, right, in their gut. And so we're actually causing more pain to our loved ones by trying to force feed them when they're trying to get rid of everything. They're trying to get rid of the fluids in their body. They were trying to get rid of everything so that they can go through a euphoric phase. And I'm talking more at the very end of life.
Mhm.
But the gradual process, families have to be accepting of the fact that if it doesn't look good, feel good, taste good, smell good, it's not going to be good for them.
Right. Right.
And I think you're providing more comfort to yourself as the family member to offer food as it is to pose to the family, the dying loved one trying to take in the intake. We're doing it to make ourselves feel better. Oh, I'm getting mom to eat. I'm getting mom to drink. But really, it doesn't feel good for them to do so. And dehydration towards end of life actually sends off natural endorphins. And so they actually get a euphoria at times during the dehydration process. But again, that is the body's way of saying, I'm shutting down. Allow me to do that. Allow me to have the experience in a peaceful manner, as opposed to putting an NG tube in me or a PEG tube and do artificial feedings, when really that's not what the body's trying to do at end of life. Those interventions are appropriate for other scenarios, but in the dying process with hospice services, it really does not bring them comfort to push fluids and food on the dying person.
Okay. So hospice is a pretty weighty word, right? It triggers people in many different ways. What we talked about the qualifications, and every single person has a different timeline, right? I've seen people on hospice for an hour. I've seen people on hospice for 4 years. What's the typical timeline from like when someone would be considered appropriate for hospice? I've been taught in the past that it's usually 6 months is, generally the time frame. Is that correct?
Yeah, so that's the Medicare CMS guideline, with a prognosis of less than 6 months of life. But you have to think about that less than 6 months of life with the current situation that they're living right now.
Hmm.
They have found statistically, if people go on hospice around that 6 month time frame, statistically, because of all the additional services of care, they actually will go not typically 90 days longer than they would had they just done the trajectory of not having hospice on board. And that
Wow.
contributes to a lot of the extra things hospice can find infections faster, get people on antibiotics if that is the course of life they want to take. We can start addressing different interventions a lot quicker. Do they need a hospital bed? Do they need oxygen? Do we need to look at antibiotics? Do we need to look at changes of medication? Do we need to start a low dose of morphine to facilitate bronchial dilatation to breathe easier? All of these things contribute to the comfort. And the minute we're comfort, we're out of pain, we can breathe a little better, we tend to have a better quality of life. And that contributes to the hospice services and having the resident statistically last 90 days longer had they not had the benefit.
Wow, that's what, 50% increase in lifespan? Wow,
Yeah,
that's pretty good.
yeah.
Not many other
And
things
I'm
will do that
I'm
for
pretty
you.
sure it's probably better now. I mean, that was, probably 10 years ago that I learned about that particular finding.
Wow, that's amazing. What, okay, so we know that hospice, so let me back up. Typically, you're looking at a 6 month window. Let's say you go 7 months. What is typically the process? Are you automatically kicked off and you're like, yeah, you're good to go? Or how does that work if you're going past that 6 month mark?
So we do in the hospice world, we do at 90 days, we do a recertification. In the first 90 days, we just have to be able to show a decline. Hospice is interesting in that in most nursing fields, and this is why it's unique, is we're always looking to better, right? We're always
Sure.
looking to let's get them better, let's get them up. We want to get them in and out, kind of like in the ER setting.
Right.
In hospice, we have to show decline. Every time that we are at a research period, we have to prove to Medicare that this resident is truly declining and still meeting the criteria. So the first 90 days, we do a research. The second 90 days, so at 180 days, we do another research. Then every 60 days after that, a nurse practitioner, a physician's assistant, or the MD themselves have to physically go lay eyes on the resident, or I'm saying resident, patient,
Mhm. Sure.
individual, and then do a justification of why they still meet criteria for hospice services. That was new in my world. So I started out where it just was 90 days, and then, they never had to see a nurse practitioner, PA, or MD. Medicare changed that in my journey, and I loved it because then there was accountability of the hospices to show that the people were actually meeting criteria and declining. You can be on it as long as the decline is there,
Mhm.
and it can be a gradual decline, it can be a significant decline, and then a plateau, and then another significant decline, as long as those particular professionals can support the the what's called a certificate of terminal illness.
Mhm.
As long as they can support that, the person can be on for an extended period of time. If they go, like you said, that 4 years, but even after a year, did we really truly assess that person? Did we get them on too soon? So there
Sure.
is that valid window of making sure, are we being appropriate in the diagnosis?
Mhm.
Is the resident improving? Can we graduate them? Which I love that word.
Yes.
Can we graduate them off? Let's see how they do. The beautiful thing about hospice services is that you can come on and off as many times as you want. There is no penalty. It's a benefit you deserve to have. No one can tell you how many times you can come on and off the service. So, do we take you off for a period of time to see how you're going to do? Are you going to acclimate? You're going to have a new baseline? Are you going to improve? Or are you going to continue to decline? And then we can put you back on.
That's
So that's kind of where that goes.
Yeah, that's pretty incredible because I know, some diagnoses are a very slow decline. Some of them are sharp, like whether it's a stroke or a heart attack or something like that. You got to
Yeah.
make some immediate decisions. So this sounds like the amount of benefits that you're getting, from hospice, from your medications being covered, hospital beds, walkers, wheelchairs. incontinence supplies. I mean, just everything. It's kind of like this all-inclusive, situation. And my understanding is that this is 100% covered by Medicare. Is that correct?
Yes, correct.
So there's no co-pays, no out-of-pocket situation for hospice.
No,
Wow. Wow. Okay. Usually there's
no.
some kind of deductible going on here. Uh,
It
that's
is something that they've paid into their whole entire life.
right.
It's a service that they deserve to have.
Right.
And, with all the DME and, like you said, the incontinence, I think the most important thing too is people tend to do better with medication reconciliations and control. When someone's in pain all the time, for example, a cancer, they have no quality of life. So when hospice gets on there, and that's our specialty, is comfort at end of life. A cancer patient actually does so much better because we are getting their pain level under control. And sometimes we even work with pain specialists to see what we're not doing, which we can be doing, and changing up and reconciliation all the time, the different pain medications. So
Which is
we
important
provide a
because
lot of comfort.
yeah, and I think that might be one of the misconceptions, of people that have hospice and, even family members that I have recommended hospice to. And I think there's a misperception that, oh my gosh, I'm going on hospice. They're going to stop all my mom's medications, including life-saving ones for her blood pressure. And they're basically just going to dope her up on morphine and let her go. And being in the business over 20 years, that is probably the opposite of what I have seen. And it sounds like
Yeah,
that's like, you're not going to live an additional 90 days on average if that's the course of treatment, right? That's just not the
right.
reality.
No, and Medicare changed their guidelines again, give some grace. I'm getting older. But they did change their guidelines. Back in the day, we could kind of pick and choose. Um, but now we can't. Medicare has come out and said hospice will provide the medications necessary to provide comfort.
Mm,
And that would include a blood pressure medication. I don't know if anyone's ever experienced a crisis of being hypotensive or hypertensive. That's not comfort in living.
sure.
Now, what hospice won't provide is something like maybe a very expensive blood thinner. Okay, what's a blood thinner? Can we get the same effects from maybe a baby aspirin? But
Hmm.
those are things that the hospice will look at. Other hospices are like, absolutely. They kind of can say, okay, is this really something that our particular company can provide, can't provide? Is the medication really, is it a chemo drug? No, they won't provide it. It's kind of
Sure.
outside the hospice philosophy of care.
Sure.
Hospice philosophy is just anything that provides um, the resident with comfort.
Hmm.
And however that looks, it's very individualized.
Sure.
So,
So let's just say someone's on hospice and they develop, a UTI. Is that depending on, again, what the resident and the family decides, is that something that you
yes.
would typically treat with an antibiotic? Or if they chose not to treat it, is it ultimately their decision?
Yes. I've had both. I've had family members go, absolutely not. We don't want to have the experience of them going uroseptic. That's just not how we want our mom to pass. Again, making
Sure.
that decision. Mom, some on our pulse form, the physician's order for life sustaining treatment, there is a checkbox on there if they do want to have artificial, feedings. Do they want to have antibiotics? Any course of action that might prolong life. But I've also, on the flip side of that coin, have had family members go, absolutely not. Would it be painful for my mom to have urinary tract infection? For some people, they don't even know they have it. Like
Right.
they don't
Right.
know they have it. They're
Yeah.
not in pain. They're not in discomfort. They're not feverish. And so we'll let the natural course of life happen and we'll keep them comfortable. So it goes both ways. If I felt like as the nurse providing the care and getting to know the loved one, getting to know the family, if I looked at them and I saw there was an elevation in blood pressure, there was an elevation in temperature, am I going to treat the symptoms and not the disease? Yeah, that's something I'm going to educate the family about, or the bacterial infection or whatever course might be. Are we going to treat it? And if we do, what does that look like? And if we're not going to treat it, what does that look like? And so, education on both sides. The hospice nurse has to be very fluid in how they approach both sides because there is no wrong. There is no wrong. You're not going to make a
Sure.
wrong decision.
Sure, because
It's just,
ultimately they have the choice, right? And they can
yep,
drop service anytime they want, and if they want to
yep.
have feeding tubes and or have chemo treatments, that's ultimately their choice. So I think there's a lot of power in that decision. And
Hmm.
the other thing we didn't touch on, aside from just the medical side of things, is that hospice provides social workers and chaplains or religious, I don't know, providers, I guess would be the right word,
Hmm.
if that's something that's important to them. And they also have these social workers that will follow the families long after the residents pass away. And I just think that's such a beautiful thing for them to be able to have someone to talk to through their grief process. And I've never worked for a hospice company, but I have seen it countless times be such a comfort and a really powerful time for families to be able to come together and enact the residents' wishes at the end of the day. So I'm a big fan.
Yeah, I've had so many beautiful experiences. We do follow them for 13 months after the passing of their loved one. But Mandy, that can be anybody. Say the loved one was very close to a grandchild
Mm,
and they pass, and the grandchild starts to not doing well in school, acting out, becoming more behavioral. You can actually call that hospice social worker and set up family meetings or individual meetings to help with the grieving process of that particular, whoever it might be. It might be the grandchild, it might be the sister, brother, uncle, aunt, anyone. But that service is for the whole entire family. It's not just for the immediate, um, you know, family members, mom, dad, whatever. It's for anyone who is struggling with the loss of that particular person. And I think that's a benefit that is it is not talked about that much. It is not, it's a piece of that education that is missing when it comes to the benefits of having the hospice Medicare benefit.
yeah,
I
it's an
mean,
incredible benefit. You don't get that with other
no.
services, that you pay for that
Mm-hmm.
typically privately. So, again, just it's no cost to the people receiving the services and just from a senior living perspective, to have hospice in there, it is just that many more set of resources to provide care and oversight. And I don't know, those hospice nurses and CNAs that work there are just incredible human beings. I have nothing but respect for people that work in that industry. So. Well, Sonia, is there anything else you wanted to share as far as working in senior living or your time with hospice that might be beneficial to people out there?
Anytime anybody ever wants to talk about it, Mandy, I'm always available. It is a passion, it's a love. I feel so blessed to have had that experience in the hospice journey with multiple family members. This is a one-time chance, right?
Yeah,
They don't get to do this again, and
right.
it's just like the birth and death is a one-time experience, and we just want to join them on their journey. And I am just so grateful for my time as a hospice nurse, as a critical care nurse, and now in assisted living, my new love.
You've
So,
seen it all. Maybe you need to do some
yeah.
labor and delivery somewhere in there
Oh,
too.
no, I'm good.
Yeah, same. I don't want to
I,
ever do that.
no.
But God bless those that do it. Thank you. We need them.
Yes, amen.
Well,
So,
Sonia, thank you so much for your time and all of your insights. I think this is really powerful, and we'll link the book that you recommend below for people that are, working through their process through grief. And anyway, thank you for all your insights, and we will see everyone on the next time. So thank you so much.
all right. Thank you.
Bye.
Bye bye.